just got off of work and there was something that came up that I kind of wanted to like tap into a little bit this morning. And when did we get into like this culture in nursing where we don't ask questions? So, and this is specific, this is like to everybody, but specifically any nursing students that follow me, any aspiring nurses, anything like that. Even if you are a new nurse, I just really want us to get back into questioning and clarifying things that don't make sense. Like the amount of I don't knows that I get when I'm talking to people about like plan of care, orders, different things like that, stuff going on with patients, is like insane. And it's okay to not know, but you should try to figure it out. Or I don't know should not be the end of the answer. You should say I don't know, but like you at least tried to figure something out. Sometimes the investigation might be ongoing. That's fine. But you just saying I don't know and leaving it at that, that's not cool. You as the nurse just saying, and I don't want to say saying I don't know, that's what the doctor ordered, is not cool, because sometimes it's just that's what the plan is. But can we have an understanding as to why, and make, like, rationales? Like, there has to be a rationale for everything. So the not questioning and the it just is what it is thing, and then the I don't knows. Like, since I became a nurse, the I don't knows is insane. It's insane. It's insane. Let me get into those real quick before I tap into this other thing. And I don't want to tussle with y'all this morning. So the scenario that I'm referring to, I get to work yesterday, I'm getting a report on a patient. So day shift is giving me report. She said, yeah, patient is on IV fluids. He's on 0.9 at 62.5. And then she says he's also on D10 at 125 cc's, blah, blah, blah. And I said, he's on 2 different IV fluids running at the same time. And I said, well, why? I said, do you guys not have D10 and 0.9? I said, they can't put it in the same bag. She was like, I don't know, that's because the doctor ordered 2 fluids. Baby, what you mean you don't know because the doctor ordered 2 fluids? Since when do we run 2 maintenance IV fluids like that? Just because. You don't. So I got so wrapped up in her saying the patient was on 2 fluids. She said, I don't know. I said, wait, hold on. I said, you said he's on at what rate? I said, you said 125. Because, you know, sometimes you mishear things. So I was like, maybe I wrote the number down wrong. And she was like, yeah. So at this point, I'm getting into the chart and getting ready to look at the MAR. So I'm reading the order. And I said, you got that pump running at 125. I said, this order stays 62.5. I said, yeah. I said, he's supposed to be on a total of 125 between the 2 bags. And I said, I assume that is because what I said. Y'all don't have D10 in 0.9, so they hanging 2 fluids to get the 1. That made sense. All the questions that I asked when she said what she said is the questions that anybody should have been asking right after. And if you don't know why you should have been asking them questions, the first red flag was when she told me the patient was on 0.9 and then also additionally on a separate bag of D10. We don't do that. We don't do that. The only time you're going to see 2 maintenances like that is if you running a piggyback you got a main line and then you got a piggyback, and whatever's in the main line is not compatible. That's the only time. So that was the first red flag. And then when she said 62.5 cc's, and then went in on to say plus 125 going at the same time, I'm like, yeah, no. So both of those questions is questioned. If it do not make sense, just like they used to tell you in nursing school, trust your judgment. Ask. I could have been wrong in what I was, the line of thinking I was thinking, but you still ask. So they had the order in there as 2 separate maintenance fluids. Yes, both of them was supposed to be at 62.5. And then there was a comment section that said 125 each bag, you know, the 62.5 blase separately to get the whole. And so I showed her. I said, no, it says, you know, this. And I said, so you got that pump running at 125. So she went in there and changed it. Mind you, she had a orientee with her, and I said, yeah. I said, are you a student? I said, are you a new grad? I said, so I ain't no girl. I said, but this is why they say when somebody tells you something, you go in the chart and you look and you verify and clarify for yourself. Because had I not gone into their chart and verified and clarified what that nurse told me, this patient would have continued running them fluids at that rate. And then you also go in the room and check your pump and make sure that that is correct. So you get your report, you check your orders and see what it actually say. You go in there, you check that pump and you check them rates. And then you check and see what is actually hanging. Have I gone in a room sometimes, in the med room sometimes, and picked up the wrong bag? Yes. But that's why you double, triple check. Yes, sometimes, you know what I'm saying, stuff get mixed up. So I might go in and be looking for a 0.9. I get LR, go in the room trying to scan it, and it's not scanning because it's not the right med. That's why you double checking. Luckily, I'm on a med surg force, so these are not cardiac patients, because this man was receiving what? 2 times, almost like double the amount of fluids that he should have been getting for at least 12 hours. So, you know, at the beginning of the shift, we fixed it. So for whatever reason, at 5 o'clock in the morning, pharmacy get calling me on the phone, asking me. She was like, oh, well, are y'all running? Because they had been charting that they was running at 125. I said, I don't know what they charted before I got here. I said, but I corrected it when I came on shift. So it's been at the correction since I've been here. I said, so if you want them to fix anything, you're going to have to talk to whoever charted it like that. Because I've been here since 7 o'clock. Why you calling me at 5 o'clock in the morning for orders that been in here at least for the last almost 24 hours? Why you calling me about it at 5 o'clock in the morning? The next thing, this is again, when you are getting a report, you check for yourself. You check that chart for yourself. You check that patient for yourself and make sure that that information is correct. So we go on, this is actually the same patient. You know, you getting a report, hey, this is Mr. Johnson, 67-year-old male, came in from blase, no allergies, patient is a DNR. So I'm checking, cool. We get to DNR. For whatever reason at this hospital, the doctors don't put in fucking code statuses on the patient. So everybody's a fucking full code, whether you want to be or not, until they put the goddamn code status in the computer and sign the papers. So nobody gets code statuses. I had 4 patients when I came on shift. 1 person had a documented code status, and I think that's probably only the second patient I've had with a documented code status since I've been working at this place. What is a code status for those that are not healthcare professionals? That is the way I ask you what you want your code status to be. That is, do you want us to save you, or if you croak, you don't want us to do anything? And I ask when I am admitting you, if anything shall happen, if your heart shall stop, if you stop breathing, do you want us to do everything to save you? Most people know what that means. If some people have questions, I give them a quick rundown. I say, if you want more information, I can connect you with the person, because everybody don't know what that means. Do you want us doing CPR? Do you want to be on life support? Do you want to be intubated? Do you only want medications? If you don't know what that is, I suggest next time you go to your doctor, y'all sit down, y'all had a conversation, and you figure it out. Because if you do not have anything documented, if your family does not know, you ratting it out. You ratting it out. And a lot of people, that's not their wishes. That's a different story. So anyway, they don't document cold statuses here, and that annoys the fuck out of me, because if we don't have it documented, if something happens right now while I'm giving you a report, and y'all, whatever happened and y'all said something about a DNR, if that shit ain't right here, I can't do nothing with that. And guess who the first people was in the room? Me and the CNA, or the nurses on the floor and the CNA. So first thing we doing, them ribs getting cracked, baby, until somebody come in here and figure it out. I mean, that's just legally what our obligation is to do. Okay? So anyway, that pisses me off that when they don't chart the damn code statuses. And if I call the doctor and ask them to put in a code status, and they tell me, no, I gotta wait till the morning, I'll put in a fucking note that you didn't put in no code status for 12 hours. I mean, whatever your prerogative is, but hey, man is man. And I guess some doctors be like at night, it's not your primary doctor, it's a covering doctor. So, you know what I'm saying? If I get the patient, I'll be like, hey, this patient doesn't have a code status. They wish to be full code. Doctor be like, well, I ain't met that patient. You know, I'm not putting in a code status because I don't know them. I mean, you could just come up and come holler at them if you feel like that. I don't know, but I have to do my due diligence, and I guess you have to do yours. But why this patient been here for a week and don't have no code status is nuts. But let's get back to the patient, right? Let's get back to the story. So I got the computer open, looking at the stuff, which I'm glad I did. So she's like, yeah, patient is DNR. I said, well, he don't have a code status charted. So I said, do we have assigned DNR? So she's like, yeah. So I'm like, okay, let me go check. So I let her finish doing a report or whatever. And so we got through all the patients, and I almost forgot to check it before she leaves. So I go grab the chart, because they don't have it, media scanned into the computer. It's still a paper, and I'm assuming it was new, especially since it wasn't in the computer. So I look at the paper. I said, hey, I said, this DNR ain't signed. I said, DNR ain't even filled out. I said, this DNR only has the patient's name on it. It don't even got a box check. I said, we don't have a signed DNR, baby. So she goes back to start re-explaining for the second time the story as to how they know the patient is DNR, why they want to be DNR, this, that, and the other. The family came and said XYZ. And I said, that's fine. I said, but y'all didn't sign this legal document. I said, it's just sitting on the chart. I said, and actually, none of the doctors don't even say shit about a DNR either. It was just the form. It looked like they was maybe supposed to start it, or maybe the secretary pulled it out and wrote the patient's name on it, and they was supposed to follow up on it. And so I'm like, yeah. I said, no, we don't have a signed DNR. So they pull out the power of attorney, and they like, oh, the power of attorney says something on it. And I said, well, okay, but they don't have the legal document or whatever. I think the power of attorney was new, or surrogate decision maker. And so I'm like, okay. I said, so if anything happens right now, I said, he's a full code. Because y'all don't got no fucking DNR. So they have, I guess, been reporting off that this man was DNR this whole time. But, and of course I get here and I'm like, well, no, he's not. I said, because his DNR is not signed. So I was just like, okay, it's fine. You know what I'm saying? Whoever just has to follow up on it, you know. But I said, but for now, he ain't full code. Like, stop reporting off that he's a DNR and the DNR is not signed. You can say, well, this used to be his DNR, but we waiting on it to get signed. Is kind of what we need to say and do. And I write that down in a special color so that I know if anything happens that this patient wanted to be DNR, but we didn't get it officiated yet. So, of course, later on in the night, now the house supervisor calling, trying to figure out motherfucking DNR. Man, this patient been here for a couple days now. The DNR situation has been a thing at least for 3 days. That's how far back the notes went about them talking to the family, since like the 7th. So I just want to know, I don't know, maybe they made it a big deal because I made it a big deal. But I just always feel like why do you, don't wait for me, because y'all had this little charge nurse, house supervisor meeting all the goddamn time, and y'all had this man written down as a DNR, and y'all don't ask him questions. So are y'all just been like, I don't know, like, what are we doing? Why is nobody checking? Why did nobody check to make, why is nobody checking to make sure, okay, yeah, the DNR signed, we good? I just don't understand. I just really don't understand what we're doing. And somebody told me on my last assignment that I be making more work for myself. Like, I go creating problems. And it's not creating problems. It's just I do my damn job. So like that, like the DNR thing, like I basically saying like I made that a situation, and it's not. It's doing what you're supposed to do. You know what I'm saying? I'm like, I just don't understand. I just don't understand. Like, what are we doing? Like, really, what are we doing? Like, we really need to get back to the fundamentals of things, because it's kind of crazy. It's very crazy to me. And I'm like, you know what? I don't know. I said, I just got here. I asked the questions. You know, all I could do at this point is expedite it up to where it needs to go. And at least I did my due diligence. Due diligence has been my word of the year, my word these last couple months. And I take pride in the fact that I come to work and I at least do my due diligence. I do what is in my reach to do. Ask the questions, try to get the answers to the best of my ability. Is kind of the best that I can do, especially in these days and ages. Because we have responsibilities as nurses, but everybody that work in these goddamn hospitals got a responsibility. Every discipline. The doctor has a responsibility. Social work has a responsibility. Case management has a responsibility. Respiratory, OT, PT have responsibilities. So I just do my due diligence to try to provide nice care